Hello, this is Dr. Frank Patterson. Today I want to talk to you about concussion and about how we can go a little bit beyond rest and medication to get to the core of your issue for those people that have lingering symptoms after a concussion. I'm talking about those people that have tried rest and medication and just aren't getting better. This talk is for everyone, but in particular for those people that have done the typical steps, whether it's rest, medication, maybe it's some graded exercise where you're gradually increasing your exercise, or maybe even some physical therapy, and you're just not feeling better. This is definitely the talk for you if that's the case. But before we get in too deep, a little bit about myself. I'm a licensed chiropractor, but I also have board certifications in chiropractic neurology. I also have a fellowship of mild traumatic brain injury, also known as concussion. And I joined the Chiropractic Neurology Center in February of 2023. I actually interned a long time ago in 2014, but it's good to be back. So what is Georgia Chiropractic Neurology Center? So we are chiropractors that specialize in multidisciplinary neurorehabilitation. It's a mouthful. But we take tenets of many different disciplines in the realm of rehab and neurorehab, and then we combine those components to utilize what's known as neuroplasticity. That's right, we harness the brain's ability to change and adapt, which is known as neuroplasticity, to restore function, ease symptoms, and help you get your life back. As I go through this talk, I'll go into specifically some of the different rehab strategies that we use at our center that really help people get back on track that have those lingering concussion symptoms. But for now, let's talk a little bit about what we're going to talk about. So our topics for this talk is what is concussion, concussion myths, post-concussion symptoms, which can lead to post-concussion syndrome if those symptoms aren't resolving. Let's talk about, does your loved one have post-concussion syndrome, or do you have post-concussion syndrome? What are some of the things we can look for in addition to the symptoms? And then typical diagnosis and concussion treatment. And then why do symptoms persist, right? Why do we have these lingering symptoms if we've done the typical things? Why is our concussion lingering? Well, I'll tell you what, it's probably because you're not getting to the root of your problem, which we're going to talk about tonight as well. And let's talk about types of concussions. Through that discussion of types of concussions, this may not be something that you're familiar with. You may have been like, hey, I got a concussion, but I didn't realize there's different types out there. We're going to dive in deep on that. But the important thing with types of concussion is basically, I would argue, and everyone at our center would argue, that if we go a little bit deeper and we figure out which areas of the brain have been affected specifically for you and your concussion, then we can break it down into rough categories of what type of concussion you've had. And then oftentimes we can get those results that have been lacking for you. And then, are you a good candidate for personalized care that utilizes these different types of concussions? So, what is a concussion? A type of traumatic brain injury when your brain is jolted or shaken inside your skull. Specifically, it is classified as a mild traumatic brain injury. Remember, that's what my fellowship is in. Although it can be misleading, and by misleading I mean, hey, what is a mild traumatic brain injury? Because oftentimes if you've suffered a concussion and you've had lingering symptoms, this is not a minor thing that you're dealing with. Even if you get a concussion and you don't have lingering symptoms, even if you're one of the fortunate ones and you're dealing with this for a few weeks, like, it can be really rough. So why are we saying that this thing is mild when it can be pretty darn serious? We're calling it mild oftentimes because when you get a concussion, one of the fortunate things is that you're not going to see a whole lot of damage on an MRI or a CT scan or imaging. And we're going to talk about this a little bit more. And, that's fortunate because we don't have like very, very, very big trauma that shows up on that imaging, right? But the problem is that there's still micro trauma that's there. It's just that MRI and CT scans aren't sensitive enough to pick it up. And also, it's a bit of a software issue in addition to a hardware issue. And it's a hardware issue that imaging isn't going to pick it up, but the way that your brain functions has in fact been compromised, and that can lead to big symptoms and sadly sometimes some big lingering symptoms. So once again, a concussion is a sudden change in direction or forceful movement of the head, such as a fall. Could be from a sports injury or even a car accident. It can cause the brain to move rapidly within the skull, resulting with a concussion. A little bit different way to describe it from our previous statement there. So this is going to lead to structural, chemical, and functional disruptions to the brain. A quarter of respondents in a survey that was done by the CDC reported experiencing a concussion in their lifetime, right? And it's honestly a little bit more than a quarter, right? It's approaching a third, right, of those respondents. So that's a pretty big deal, right? That we have that many people in the population that have reported having experienced a concussion. And then, there's people that have those undiagnosed concussions that really aren't quite sure. And we're going to tell some stories about some patients where they didn't quite know what was going on either because it didn't seem like a straightforward concussion to them. And part of that is because we have these myths that are within concussion, right? That we think that a concussion is this thing, but it's actually something else. Most of us have a rough idea, but one of the things that's very confusing is that you don't even need to hit your head. If you really paid close attention to the definitions that I gave you, you may have noticed that I was talking about a sudden change in force, but that doesn't mean that your head collided with something. You could be in a car accident and have a whiplash injury without striking your head on some surface on the car. You could fall and catch yourself on your arms, but your head whips forward really hard, right? And it's a sudden change in force, and it's disrupted the function of your brain, and you wind up with a concussion. Oftentimes, we'll have patients that talk about some kind of accident or a fall, and it's severe enough to where they broke a limb. And, when we hear that, and they have these symptoms that sound like a concussion, it makes us wonder, because, if it was a force that was severe enough to break a limb, it might have been severe enough to rattle that brain a little bit and lead to a concussion. Well, another thing that is a little bit confusing for people sometimes is you don't need to lose consciousness to have a concussion, right? You can be fully conscious. Just to give an example, there was a patient that I treated for concussion where he was on a flight with a little bit of turbulence, and he wound up striking his head against the overhead compartment. Not a super hard hit, I did not think much of it at the time, but after hitting his head, he had a little bit of a headache for the rest of the day, and then he felt pretty good for a few days. And then about a week later, he was at work, high power executive, and he's realizing that people are working at what's normally his fast pace, and he just cannot keep up with them, right? He's cognitively a little bit slow, his memory's slipping a little bit, and normally he's sharp as a tack. And this is all from just some turbulence on an airplane and striking his head. And one of his questions was, he's like, hey, I know I had some concussions in college when I was playing sports, and this hit was nothing like that. So it doesn't need to be something that really rings your bell to give you a concussion and leads to loss of consciousness, right? It could be a seemingly minor hit that could lead to a concussion that could have lingering effects, as it did for this man, because he was dealing with this for months, and he was worried about losing his high profile position in his company, that he was considering retirement at one point. At one point. You can see it on MRI or other imaging. Like I talked about, you don't necessarily see a concussion on imaging. You're probably not going to, right? You're probably not going to. Rest, medication, and graded exercise are the only options. That's a myth as well, right? We're going to get into that tonight about what other options are out there for you. So concussions resolve in a few days. Sometimes, if you're fortunate, yes, that's what we're always hoping for. But there's so many people where it's been months or years and they're just not getting better. Excuse me. So let's talk a little bit about these post-concussion symptoms. Okay, so post-concussion symptoms can be varied significantly in severity and may arise from a head injury regardless of its cause, right? Symptoms can appear immediately or several weeks after a concussion, like I talked about that patient that I worked with that was on a flight, and his big symptoms didn't happen until at least a week later. Post-concussion symptoms. What are we talking about here? Typically, we're talking about things like we're talking about headaches. We're talking about dizziness and balance issues. Patients may feel as if they are spinning or unsteady on their feet, right? Cognitive changes, difficulty with concentration, memory, and processing new information can occur. Visual disturbances such as blurred vision, double vision, or sensitivity to light are common. Nausea. Some individuals may feel queasy or experience vomiting. Fatigue, increased tiredness, and lack of energy can accompany a concussion. Mood changes such as emotional disturbances like irritability, sadness, or anxiety can also manifest. So we're talking about a lot of different things, and don't get me wrong, this is not the end-all be-all list. There's so many other symptoms that can be involved as well. But the problem is that all of these things, on their own, let alone if you've got multiple of these things, can really make living your life difficult. And some of the people that we see that have post-concussion syndrome, these lingering symptoms where it's been months or years and it's just not getting better, that's a real problem, right? Because if you've got these severe symptoms, you're just not going to be able to function in your job. And we've had people that have had to step down from their jobs, right? Or step down from school. So what is post-concussion syndrome? PCS is the continuation of several or all of the initially reported symptoms that were associated with concussion. And sometimes those symptoms evolve over time, where at the beginning of it, you have certain symptoms and then some start to pop in over time, which can make things more confusing and more complicated as well. So if your symptoms continue past 10 to 14 days if you're an adult or greater than 4 weeks as a child, then you most likely have post-concussion syndrome. There's some debate at this point that, we're really talking about all people after 4 weeks. But the bottom line is that it's been weeks, right? Certainly anything greater than 4 weeks, and you're likely dealing with post-concussion syndrome where you have this lingering concussion. Right? And the problem is that PCS can last months to years, even possibly a lifetime. Not fun, right? It is a myth that all concussions resolve within a few days. Does a loved one have PCS? So what can you look for in an individual, in addition to them being like, hey, I've got these headaches, I've got this fatigue, I always feel dizzy, right? I feel off balance. You could see what's called a loss of affect, which is decreased facial expression, a loss and inflection in their speech. Sorry, they're just really flat. And they're just, they're monotone, and they used to have a lot more inflection in their voice, and they used to get excited and animated, and now it's just kind of one monotone stream that comes out, and they might have a loss of normal upright posture, more, maybe they're usually bright and awake and standing up nice and tall, and now they're just slumped and they're just speaking softly, and there's not a lot of emotion in their tone, and they just have that glazed over look, right? That's our loss of affect. They may be sleeping more or less than usual. You may notice slowness or absence of response to questions or requests, right? You may notice that they're moving slowly. You may notice that, they've got a lot of nausea, and there's a fair bit of vomiting that happens, or at least they're close to it sometimes with that nausea that's persistent for some people. You may notice the balance issues, not just that they feel unsteady on their feet, but you may notice them bumping into things or tripping a lot more or just falling, right? Or just looking unsteady on their feet. And then you may notice that they withdraw from family and friends, that you just don't see them out much. They'd rather be in a quiet, dark room where they don't get overstimulated. And it can be really rough. You may notice irritability, anger, and defiance, right? You may notice those personality changes. And it's because they're dealing with post-concussion syndrome. You may notice sadness or negativity, also some emotions that are involved. So let's talk about how concussions are typically diagnosed. We know, on this slide it's a little bit misleading. We know that the imaging's not heavily involved. Still, don't get me wrong, still an important thing to do. We want to get that imaging. We want to get that CT scan right after the incident happens, right? We want to get maybe an MRI. I think an MRI is a good thing. But oftentimes we're not going to see much on the MRI of a person that's been concussed, even though we've got some things on the imaging that we're seeing here. Examination. It's typically diagnosed with a patient history describing what happened and what the symptoms are. You're going to have an examination and maybe a brief cognitive assessment. They might orient you to place and time, meaning like they're going to ask you what year it is, roughly what time is it, what day of the week is it, who's the president, things like that. And then one of the challenges is that there's no lab tests to diagnose concussion, right? And there isn't great imaging to diagnose concussion either. So then, how do we diagnose it? Right? There's no blood work. There's no urine analysis. There's a lot of search out there. I've been to research conferences where there's so much talk about what are the biomarkers for concussion. The good news is there are biomarkers, okay? It's just that we don't have lab test biomarkers. We don't have blood and urine type biomarkers to help diagnose concussion, okay? There's some cognitive things we can look at, right? And we talked about it here, but there's also some other things we're going to get to in a bit. So yeah, advanced imaging such as CT and MRI are generally not helpful. People talk about functional MRI or fMRI, but that's rarely used in clinical practice, which is a challenge. It's used a lot in research, but it's rarely seen in a clinic where you're going to get treatment. So, but like I said, it's important because these tests can show you something like a brain bleed, which if you've hit your head and you're like, oh, maybe I got a concussion, well, you might have a brain bleed too. So that's why they're going to run that CT scan or maybe that MRI. In particular, they're probably going to run a CT scan first because it's faster, right, to get quick results to see if there's a bleed on the brain. Important thing to do, but it's not going to help you with that concussion diagnosis. Other than, hey, we don't have a brain bleed, but they're having these issues based on their history and this little cognitive assessment that I did, so they probably have a concussion then. It's kind of a diagnosis of exclusion to a certain extent. But just because imaging is negative, we know that it doesn't mean that there isn't a problem. There can definitely be a problem, right? So typical concussion treatment, what are we talking about here? We're talking about watch and wait, okay, which is effective to a certain extent. The watch and wait thing can be helpful, but you can only sit in a dark room for so long. And what they're finding in the research now is that they only want you sitting in the dark room for so long, okay? They want you to start doing what's called graded exercise after maybe a day or two of sitting in a dark room, exposing yourself to some exercise. Typically, what we're talking about is just walking at first and then kind of building up from there, okay? So the typical treatments in addition to that are painkillers and antidepressants, that gradual graded exercise, like I said, and sometimes physical therapy for the symptoms. But why do the symptoms persist? Why do the symptoms persist? Well, part of the challenges is treatment is typically symptom management. Every injury affects different areas of the brain. If you can't find the root of the problem, symptoms are going to get worse over time. Right? So those medications may help you with the headaches or reduce your nausea, but it's not changing your brain function, which has been altered in the first place. We need to rewire the brain. We need to harness that neuroplasticity, but that's not in the typical treatment. I would argue that too many doctors and specialists focus on brain structure and not enough on brain function, right? We need to harness that neuroplasticity, but we need first to understand which areas of the brain have been affected. And we're going to talk about how we do that at Georgia Chiropractic Neurology Center. So standard imaging like CT, right? And MRI, we put too much weight on that. And you need to systematically test the function of the brain to get to the root of your symptoms. Right? If we want to get to the root of the problem, you need to systematically test brain function. But the unfortunate thing is that's not typically done. We're very unique here at Georgia Chiropractic Neurology Center, and I like being unique, and I like giving a higher level of service, but I just wish that was the standard of care, because that's what people need. So concussion symptoms don't have to last months or years when you address brain function with the right exercises, right? And you find the root of the problem. So when symptoms are persisting, this is based on a consensus statement on concussion in sport, and it was the 6th International Conference, and it was in Amsterdam. And this happened back in 2021. Paper was written in 2022. It's the most recent conference. They do this every so many years. But, hey, you could be like, hey, like, I don't have a sports concussion. Like, I just hit my head, or, I fell down the stairs. I didn't hit my head, but I just seem to have a concussion now. But sport is where a lot of this is really being looked at. And this is a well-respected conference where a lot is dictated as far as how we just handle concussion in general. And what they were talking about at this conference most recently is when symptoms are persisting, worsen, or are not progressively resolving after 2 to 4 weeks post-injury, hey, we're getting into post-concussion time, right? A multimodal evaluation and referral for rehab is recommended. But unfortunately, the story that we get from our patients is that it's just not happening. It's just not happening. I don't know why. Part of this may be that there was also a separate study that was done at one point where they looked at how long it takes something to go from research. So say this was published in 2022. How long does it take for something in research to stand a chance? Now, I'm not saying it's going to always implement it, because often it's not, but how long does it typically take for it to stand a chance to show up in clinical practice? The answer was 17 years. So hopefully by 2039, we're going to see this on a regular basis. I don't think that's appropriate. I don't think we need to wait that long. That's why we're doing this talk, right? Because we need to get the word out that you need a multimodal evaluation and you need some rehab to get to the root of the problem. So let's talk about how we do that. So let's get to the root of the problem. There's 2 different ways to look at examining a concussion, and I kind of touched on this. You can look for the markers that typically indicate a concussion, right? Just a concussion, which is like history of hitting the head or a sudden change in force, or just, the head whipping around. Symptoms, cognitive challenges, balance issues, right? Slurred speech, pupil dysfunction. Those are some of the findings that they're going to see during the examination process. And they're trying to rule in or rule out concussion, right? And they'll do that imaging, which is great to make sure that there isn't, more severe trauma to the brain that shows up on imaging. But I would argue, and all the doctors here at Georgia Chiropractic Neurology Center, and apparently, the experts at this conference, feel that you need a multimodal evaluation. So if you systematically test different areas of the brain with your examination and your diagnostics, then you can uncover what type of concussion it is and how to rehab it. And we recognize here at Georgia Chiropractic Neurology Center that specificity is the key, even down to the fact that men and women are affected by concussion differently and heal from concussions differently, right? We've looked at this with one of the pieces of technology that we utilize in our clinic that measures pupillary size, right? It's great to shine a flashlight in there and get a quick look, on the sidelines at a sporting event. But it's a heck of a lot more powerful if you utilize some of the technology we have, like this pupillary reflex application that allows us to specifically measure the diameter, right? How quickly the pupil closes, how quickly it opens. This is tracking what's called your autonomic nervous system function, and we're going to get into that a little bit. But when you use more specific technology like this, we can track your progress as far as like, how are you getting better? And the interesting thing is that we see different things, whether it's a man or a woman, right? So we need to take this into account as far as like what your biological sex is, because that's going to help guide us in your treatment process. And that's going to help guide how are you healing, because men and women heal differently and they have different needs as far as rehab. Now, if you'd like to check out a blog that we wrote about some research that was done on the sex differences between men and women, I'll have that at the end of this presentation. So once again, getting to the root of your problem, we need systematic testing of your brain function to diagnose which areas of your brain have perfected, and we're going to prescribe and perfect the right rehab strategies for you. And we need to exercise your brain to get it back on track. So how do we do that? It's a 3-hour process, which is not typical in healthcare. Remember how I said that we're kind of a multimodal, we're looking at a multimodal evaluation, but I also talked about how with chiropractic neurology, we're combining components from different professions in healthcare because we need to look at you as a whole. You know, it's a brain injury, but your brain controls your entire system, so the effects show up in your entire system. So to be able to track it back to your brain, then we need to look at the entire system. So how do we do that? We're going to do an in-depth history and records review, which is sadly a bit of a lost art in healthcare, right? We don't often have in-depth histories taken, and oftentimes, records aren't looked at as closely as they should be. We're going to look at your vitals. We're going to look at your heart rate, your blood pressure, and your oxygen. And we're also going to look at it in different positions, right? This is where, some aspects of cardiology. We notice with a lot of people that have concussion, they have issues with their autonomic nervous system. Those automatic functions or autonomic functions that your brain really guides the processing of. So we're going to check heart rate and blood pressure and oxygen sitting, lying, and standing, because a lot of people with concussions, not all, but a lot of people with, I should say, post-concussion syndrome, they can have issues where their blood pressure may be different from side to side, or they may have big increases in heart rate when they stand up, which can be a part of their dizziness, nausea, fatigue, headaches, kind of a lot of their symptoms. So we need to look at that. And oftentimes blood pressure is just taken on one arm with you seated. That can be helpful too, but not as helpful as digging in deep to get to the root of your issue. So that's the cardiology aspect. Now, something that typically is done in an ear, nose, and throat doctor's office or an ENT's office or maybe at a vision therapy clinic is they're going to do eye movement testing, because different eye movements of different types, whether it's a tracking eye movement, right, or it's a fast eye movement where your eyes jump from target to target, like me flicking my thumbs, the eyes go side to side. Different areas of the brain control those different eye movements. So there's a lot of technology out there now that revolves around tracking the movements of eyes to help diagnose not only concussion, but other types of brain injury or neurodegenerative issues that have specific eye movement deficits as well. So that helps us uncover the areas of the brain that are involved. We're also going to do a balance assessment. Sometimes you see that in physical therapy. Well, you know what? You see it a lot where they'll have you go eyes open and then eyes closed on a foam pad, and they're going to watch you and see what happens. Very powerful tool. Very powerful tool. But we're going to take that to a higher level here at Georgia Chiropractic Neurology Center, and we're going to put some numbers to that. And we're going to talk about how we do that with computerized dynamic posturography, where we have some specific numbers that you need to hit, right, based on your age range, to have good balance, and your brain is in control of good balance. We're going to talk about that a little bit more. And then cognitive testing that you'd often see in a neuropsychology office. We're going to, not as in-depth as a neuropsych eval, but we're going to do some more in-depth cognitive testing than you're going to get, say, in a hospital environment when you initially get that concussion diagnosis. And then we're going to do a thorough physical examination that you might have at a neurologist's office. But we're talking about something that lasts typically like 30 minutes to an hour, okay, at least. And different areas and networks of the brain have different jobs to do. So we test those different areas of the brain through our physical examination process. We're going to look at sensory processing. We're going to look at movements, muscle tone, cranial nerves, right? There's different cranial nerves that have different functions, like controlling the musculature of your face and also controlling sensation in different areas of your face, pupillary constriction and dilation. Different types of eye movements, right? So there's different things involved with the different cranial nerves. And then we're looking at just observation of your coordinate gait and balance, right? Gait meaning you're walking. So let's talk about the right rehab for your brain. That's how we uncover things. So we're going to get all these different check boxes for these different areas of the brain through our diagnosis and diagnostic process. So we might find that for Sally, like it was her right frontal lobe that was injured. And maybe more specifically, she's having issues with her orbital frontal cortex, or maybe her prefrontal cortex in that frontal lobe. Or maybe she's having issues in the top part of her brainstem, which have a relationship with her autonomic nervous system processing, which she's having autonomic nervous system issues, which leads to a rapid increase in heart rate when she stands, which leads to nausea, dizziness, fatigue, headaches, all kinds of issues for her. So no two concussions are alike, so no two rehab plans should be alike, because different concussions have different areas of the brain that are affected. Different people need different exercises at different levels of stimulation. And the GCNC doctors, we here, create a precise plan of therapeutic exercises to target the specific areas of your brain that need to be rewired, a concept known as neuroplasticity. Remember, we mentioned that a few times at this point. And I touched upon the different levels of stimulation, right? Some people can handle a rigorous 30-minute rehab program that we do with a lot of patients. I've had patients where I can't spend more than 10 minutes with them at a time. I might do a few 10-minute sessions with them over the course of the day. But if I go longer than that, their system fatigues. And yeah, they don't really necessarily feel it yet. But if I go beyond that, pretty quickly, they're going to start to have an increase in their symptoms. Their autonomic nervous system processing is going to go down. Right? And they're just not going to feel well. So we got to catch those things early. So let's talk about how we can better help you by talking about some of the advanced examination tools, right? Oh, well, we already talked about that. Sorry. But anyway, types of concussions: vestibular, ocular, mood and anxiety, migraine and headache, cervical, executive function. So let's talk about these different types. Let's talk about vestibular concussions, right? That's inner ear processing. Issues with balance and dizziness and vertigo. That's often what's seen with a vestibular concussion. But you can get headaches, and while you have a vestibular concussion, vestibular type concussions can also lead to cognitive type issues. And the challenge is you don't just have to have one of these types of concussions. It's often an overlapping of the different types. But these different types, some speak more to some people. So an example of how we diagnose this is what I was talking about earlier. That's even better than just watching somebody with eyes open and eyes closed on the foam pad. Let's have them stand on this plate that you see in this picture here, right? And then we can give them things to look at. We can kind of mess with their vision with that VR, right? And then we're going to get information about different systems that we have numbers that are attached to it, so we can track people's progress. So these are different systems in your nervous system, in your brain, that are involved with balance. So there's your visual system, there's your vestibular system. Those are the last two. The first one might be a little tough to see, but the first one is somatisthesia, or somatosensory processing, or what's known as proprioception, which is information that comes from the joints and muscles in your feet and ankles. Right? All these different systems are processed by the brain. If processing one of these systems is off, it can lead to issues. And one of those in particular is vestibular. So we may see that instead of hitting their level of balance, hitting that black line, right? If they don't hit that black line, their bar does not turn blue. It stays orange. In this person's case, the data that we got is indicating visual issues. They have like a more ocular or visual type issue with their concussion. Okay, so how do we rehab when it's an inner ear concussion? Or what's known as a vestibular concussion. It doesn't mean you specifically concussed your inner ear. It's your brain's interpretation of the information that's coming from the inner ear. Those areas of your brain that interpret that information, those have some injury and wiring issues. And software issues. So an example therapy is what's known as gaze stability exercises. So I'm going to create a target for my eyes. I'm sorry if it's really close to you, but I've got a target here. Let me lower it a little bit. And then I'm going to look at this target and I'm going to move my head back and forth. And I just had a consult with somebody that was telling me, she's like, I've got this exercise, I've done it, but I feel terrible when I do it. And certain exercises are the right exercises for some people, and other people need different exercises. But what this does is it helps reprocess your inner ear function. It helps reprocess input from your joints and muscles in your neck, and it uses your vision to help guide the processing of your neck joints and muscles and your inner ear processing, and it can help rewire your inner ear processing so that you have less of these vestibular symptoms because your inner ear is processing things more appropriately. Anybody that's been in our office has seen tons of dots everywhere, and there's a lot of head turning going on because it's a really powerful tool. So getting back to that woman's story, though, she's talking about how this made her feel terrible. Well, I haven't examined her yet, so it's maybe that's not the best exercise for her. But there's been several people where I've examined them, and they're like, I've done this before. As I'm explaining to them, I'm like, all right, well, we're going to do it a little bit different. We're going to do it as we go back, in our presentation, I talked about we need to do things at the level that you can tolerate, at the speed and level that's most appropriate for you. So we need to do it maybe slower for this woman, because she was talking about, they are like whipping her head back and forth. And that can be a bit much for some people. There's some people where they can't go slow. They need to go faster. If they go slow, based on the eye movement testing that we've seen with them, we notice when they go slow, like things break down. It doesn't work so well. And then lo and behold, their eyes can't stay on the target that they're trying to follow. And they just don't feel well. So we got to do it fast for some people, slow for others. I don't have a stack of exercises that I can give you and be like, these are your concussion exercises, right? I gave them to 5 other people that came in before you. This is just what we do for concussion. Doesn't work that way at our clinic. That works for some people some of the time, but there's so many people where that works not so well because they need specificity. They need that multimodal rehab. So let's talk about ocular concussions. Blurred or double vision is what we're typically experiencing. Diagnostic tool that's involved is what's known as video nystagmography. I just talked about it with the inner ear processing. Guess what? This also gives us a window into your inner ear processing as well. There's crossover between all these systems because different areas of the brain are interrelated with each other. It's not just the frontal lobe does this and it does it in isolation. It works with other areas, such as that top part of your brainstem. It works with an area called your cerebellum. It works with so many different areas. So blurred or double vision, we want to look at not only like your visual acuity, like it's great to go to the optometrist and say, fuzzy clear, do we need a new prescription? We want to look at, how are your eyes moving together, right? And then are they moving together, or are we having an issue where the eyes are moving and like one gets ahead of the other and then the other one catches up, right? They need to work together as a team. Okay, there's sometimes where we see like a wandering eye, right? Where it goes off, right? And one's pointed here and the other it's off a little bit in that direction. And that can lead to some double vision because it's not always a constant thing. Sometimes like as the person's brain fatigues, the eye drifts and then the double vision comes in. So there's our video nystagmography tool. It's a set of goggles that track the movements of the eyes, that give us a video readout that you can see on that TV screen there. And then it gives us a graph of what the person's eyes are doing. It's a powerful, powerful tool. And it's great because we can look at the video and we can look at the graphs and be like, hey, this is where you're at before and this is where you're at now. And lo and behold, you feel better too. Right? And then we know that it's not just a placebo effect because your brain's functioning better and you feel better. So how do we start to address this problem if you've got ocular alignment issues, right? Where your eyes aren't pointing in the same direction or they're just not tracking, especially if they're not tracking this upper brainstem activity of converging and diverging your eyes. Other areas of the brain are involved with that to a certain extent. but in particular, it's a big upper brain exercise. So we've what are known as Brock beads, and you can see them in the picture here. So you hold them up to your nose like this woman is, and then she's practicing converging and diverging your eyes. So you might see this in a vision therapist's office, right, where they're working on convergence and divergence of their eyes. But we want to do it at the distance that makes the most sense for you. Sorry, I'm having trouble staying on camera here. Like how long does this string need to be? Right? So specificity is very important when we're doing all our exercises. So what about mood and anxiety concussions? These are emotional disturbances such as irritability and anxiety. Example diagnostic tool in particular is a history, observation, and questionnaires that we provide to really find out like how your mood and anxiety has been. We also, oftentimes we recommend that people bring a loved one in with them because sometimes they notice things that you may not notice if you're the person having the symptoms. And your loved ones, they may have noticed the change in you. So it can be very helpful in talking to them as well. Now, what types of therapies can we do for this? So, things like cognitive behavioral therapy can be very important, but an area of your brain called your frontal lobe helps regulate your mood, right? Helps regulate your thoughts, helps you problem solve. But in this case, we're talking about mood and anxiety, but it helps regulate your mood and your emotions. So sometimes when we activate those frontal lobes more, people feel calmer if they're anxious, or people are brighter, if they've been a little flat. So how do we do antisaccades? I was talking about the thumb wiggles earlier. So antisaccades, instead of, let me use balls instead of thumbs because they're a little bit tough to see with the background. But like if I was like, all right, you're going to look at the ball that wiggles, right? This is a saccade. It's like, hey, look at the ball that wiggles. An antisaccade is look at the ball that opposite the one that wiggles, or look at the one that doesn't wiggle when one of them wiggles. So like if I wiggle the red ball, then the eyes are supposed to go to the green ball. If I wiggle the green ball, then the eyes are supposed to go to the red ball. Okay? So we need to not just react to the thing that's moving, which our brain wants to do. We need to fire the frontal lobes a little bit more. It's already a frontal activity, just jumping our eyes from side to side to the thing that moves, but it's a little bit even more of a powerful frontal lobe activity when we have to do quick decision making, because that's one of the other things that the frontal lobe has to do, right? By ignoring the things that moves that we reflexively want to do, right, and looking at the one that doesn't wiggle. So migraine and headache concussions. Example diagnostic tools is autonomic testing with vitals, right? We talked about how that autonomic nervous system issue can lead to things like migraines and headaches. It's usually a frequent and intense headache. We're also going to palpate too. At the end of the day, we're also chiropractors and we have advanced training in chiropractic adjustments. But we also, here at Georgia Chiropractic Neurology Center, have advanced training in a system that's known as myosynaptics that was developed by our clinic director, Dr. Mark Ellis. And he has combined neurorehabilitation, myofascial massage type work, and some of the martial arts that he's learned over the years as well. Not to say that, we're going to we're not going to strike a person like you might in martial arts, but to be a high-level martial artist like Dr. Ellis, like you need to have an advanced understanding of the human body, how it moves, right? And how it moves well and how it moves not well. So in combining neurorehab, his martial arts knowledge and his knowledge of the body that he's learned from that, and the knowledge of the body that he's learned from a myofascial perspective, doing body work can have an effect on brain function, and we see it all the time. It's really cool stuff. I've experimented over the years, And I've done straight up neuro rehab with minimal chiropractic adjustments and no myosynaptics work. I've gotten pretty good results. And I've done neuro rehab with chiropractic adjustments and with neuro rehab strategies, like some of the exercises that I described already and so many other movement and sensory based exercises. And I've gotten even better results than just the neuro rehab in isolation. And the best results I've seen is when I combine chiropractic adjustments, myosynaptics, and then other aspects of neuro rehab, right? All the things that we've talked about so far and that we're going to talk about. So it's a powerful tool when you combine these different things. So how does this affect migraine and headache? How does this autonomic nervous system function affect that? So with migraine and headache, we're usually looking at blood flow and how it flows, and your vascular system can sometimes be a factor in migraines, right? Or even not, if it's technically not a migraine, and with headaches. And then this diagram that you're seeing is not blood flow patterns. It's these different myofascial trigger points. And they can, so if you look at the little X's that are on some of these things, and I don't know if you can see my cursor. I've got too many screens open here. But if you look at the little X's on the neck in these diagrams, or on the base of the neck, kind of shoulder type area, those are where like the little trigger points are. They're these little myofascial adhesions, right? And irritated areas of the fascia. If you press on one of those, you can oftentimes feel an increase in the pain areas in your head. And it's not to say, oh yeah, if I press there, then I cause these areas of pain that are in red or blue here. It's that the trigger point itself is already causing that. And and that if we work on that area and we make it work more appropriately from a myofascial standpoint, where the muscles and the fascia that covering over top of the muscles are sliding appropriately and moving together appropriately, and things aren't bunched up and irritated, then these pain patterns can resolve. And it's interesting because sometimes I'll show a patient one of these pictures and they're like, yep, that's me. That's my headache. And then I'll push on the spot and they're like, oh my gosh. Like, yeah, it lines up with the diagram. And then we work on those areas and they're like, oh my gosh, I'm so much better. One of the challenges is that this can come back. Because it may be a pattern that you're going into to compensate for something with your brain function. And sometimes doing the myofascial work is enough and the pattern, doesn't come back. But sometimes people get stuck in patterns and they go back into these myofascial patterns. And that's when we need to do the other exercises to rewire the brain so that you don't go into this compensatory posture maybe, right? That's associated with this myofascial issue. And there was also a vagus nerve stimulator. Let me go back. I apologize. So the vagus nerve has been shown to be a powerful tool as well. And then you put this along the vagus nerve. This is a stimulator, right? And then it activates the vagus nerve, which can activate an area of your autonomic nervous system called your parasympathetic nervous system that can help better regulate your vascular system that may be a factor in your migraine and other factors as well. So there's different vagus nerve stimulators out there, and it's a popular thing now. There's so many of them out there. We tend to use ones that have been well researched, and this one in particular is very well researched and is in particular known for things known as cluster headaches, but also they're pretty darn good for migraines as well. So that's one of the tools that we use in the clinic as well. So let's talk about cervical concussions, getting back to the neck, right? We talked a little bit about the neck there. So there may be neck pain associated with the injury. Example of a diagnostic tool is a physical examination, right? And then treatment, we're going to use myosynaptics and chiropractic adjustments. There's some other diagnostic tools that we utilize, some other therapy tools, but these are powerful ones, right? So when we move the head into different positions, we're utilizing our neck, our inner ear, and if our eyes are open, we're using our vision. And sometimes one or more of these systems is giving poor feedback to the brain. It's not being processed appropriately. And these three systems are cross-referenced: your eye, your vision, your inner ear processing, and your neck processing. We have some patients where they have severe vertigo and they're like, I've done vestibular rehab and it's just not helping me. I've done like vision therapy. That's not helping me. And it's like, all right, well, let's take a look at your neck. And we dive into it. It's like, yeah, your neck is a mess. And we work on their neck and their vertigo gets better, right? Which typically is thought of as like an inner ear processing thing. And sometimes our vestibular type tests improve after we've worked on, say, vision or neck processing, because like I said, all three of those systems work together and they cross-reference each other. Now let's talk about executive function concussions. Difficulty with focus, organization, processing, for example. So, we're thinking in particular that frontal lobe with this one. Diagnostic tool is known as C3 Logics. So this is a neurocognitive assessment. Like I said, it's not a full neuropsych eval, but this gives us some good information. So that SAC section that you may be able to see on here, the very first one on the far left, that's a little bit, well, it's not just orientation, like I said, like person, place, and time, but it's also delayed memories in there in the standard assessment. And then repeating digits in a reverse order, some standardized cognitive testing, right? And you can see that we get some data. The data in green is what the patient has. And then the data in the blue is 50% of the population, right? The 50th percentile. The 50th percentile, the average person. What kind of numbers are they getting? So if your numbers aren't as good as the average person, and you're before and above average person, then, hey, we want to do some cognitive rehab with you and then retest this and see if your scores get better. In fact, we want to use multimodal rehab with you. I've done some rehab with patients where most of it, even though they're having cognitive complaints, most of it was for inner ear processing because they had inner ear processing issues. And that feeds into your frontal lobe function. And their executive function, their frontal lobe function got better. These tests got better. They felt better. They were functioning better. They were sharper. Their memory was better, right, from doing inner ear rehab, which is typically done for just dizziness. It's all interconnected. You want to get to the root of the problem by seeing where everything interconnects and doing the right exercises. So this is a great tool. So we can see, like, hey, let's take the test now, let's take it later, compare the results. Are we progressing? Ideally, everyone would just take this test like once a year, so we'd have a baseline of you. Certainly, if you're playing sports, you should have some kind of concussion baseline, but it's not how it's typically done. But still, we get a baseline with you when you're in the clinic, and then that's your baseline, and then let's see it improve. Go, no-go exercises for executive function. I've got some balls on the screen here, and I got some balls in my hand. So you're the patient. We're going to catch the red ball in your right hand. We're going to catch the green ball in your left hand. And then we're going to catch the blue ball in both. And then we're throwing them back and forth to each other. And I apologize. I just dropped my water bottle. It's fine. So we got to catch the correct ball. And sometimes we're throwing it back and forth super slow. Sometimes we're throwing them back fast, right? And then we start to change up that pattern. Now the green ball is the right hand, the blue ball is the left hand, the red ball is both. And it's quick decision making. Got to grab that ball real quick with the correct hand, right? For the correct thing that we're doing at the time. Gets those frontal lobes working, can work on that executive function. Now the interesting thing is that oftentimes this neurocognitive assessment that we talked about is done and it's like one of the primary tools to diagnose concussion. But once again, during that 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 conference, in the research, it's talking about the results of computerized neurocognitive tests should be interpreted in the context of broader clinical findings and are not to be used in isolation to inform management or diagnostic decisions. So it's a powerful tool, but we don't want to just do this. Some people, they do what's called an impact test, which is a great tool, but the impact test should not exist in isolation. You need to test balance, you need to look at eye movements, you need to look at the whole picture. So are you a good candidate for GCNC care, right? Are you a good candidate to look at the root cause of your issues? So people come to see us at GCNC, Georgia Chiropractic Neurology Center, where their concussion symptoms aren't improving. Does that mean you should wait a month? No, not necessarily. But if it's been a month and you're not improving, you need a closer look. You need a thorough examination, looking at many different factors to get to the root cause, and then you need customized care. So if you've seen multiple practitioners for your concussion, you deserve a closer look. I'd recommend contacting our patient care coordinator, and we'll do a complimentary consult with you. So there's our contact information. Now, if you've listened to this and you've had more questions, then I'm happy to do a consult with you. We want to make sure that the right people get to the right place at the right time. If you just got your bell rung, you were in a car accident, and you call us up, I'm probably going to recommend that you go to the hospital. I am going to recommend that you go to the hospital, right? Because we want to see if that brain bleed's there. You need that imaging, right? But if you're out of the hospital, and you're just not getting better, then you need to come see us. But yeah, don't hesitate to call, and we'll do a complimentary consultation. We do them all the time. Sometimes we know some people that do similar work to what we do, and they live in your area, and we could send you there. So we see people from out of state, out of country. I've worked with patients from the country of Jordan, from Norway, all over Europe, Canada, so many different places. Unfortunately, a lot in Marietta, where our clinic is, and a lot in the Atlanta area, because there's just so many people that need help. But, we've got some good colleagues in some other areas as well. But unfortunately, there's just not many people that do the work that we do. So give us a call. Let's do a consult. Let's find a good place for you to go. It may be us, or it may be one of our colleagues that is closer to you. But at the end of the day, our goal is we want you to feel better. We want you to get to the root of your issue. So don't hesitate to reach out, and I thank you for your time. And if you learned some good things today, or a loved one that fits the description of what we talked about today, then I ask you to please share this video. And if you can give us a like, that's great. Please share it. If you're like, hey, what was that autonomic nervous system stuff you're talking about? We got talks about that. Things like dysautonomia, POTS, triple PD, which is a type of vertigo. We got a vertigo talk. We got all different talks for different complex neurological conditions. So check those out on our YouTube channel as well. Thank you for your time, and don't hesitate to reach out if we can be of help.